I'm going to speak on a subject which, when Jerry said to me, will you give a talk on the limits of harm reduction, filled me with great anxiety. Partly because I've written some unhelpful contributions which may fall under the umbrella of the limits of harm reduction. And partly because I felt that there would be many people in this audience who would not necessarily want to hear me talking about those limits. So I'll try to offend as little as possible whilst making at least some contribution. The other thing to say is that I have no responsibilities to make people's lives any better, which in a sense is a release from what is a rather substantial responsibility. So my role, if anything, is to think about things and to write about things. And that's the only contribution that I can make, because I'm not an interventionist, I'm not a social worker, I'm not a doctor. But I want to say something about harm reduction, and I was struck by Jerry's question about this issue of the trust or the lack of trust, because it seems to me that we are familiar with the difficulties of speaking truth to power, and those difficulties are substantial and costly, actually, in many different ways. But the role or the space of trying to do research in this area is a bit like being a small country with a neighbouring very large country, and the preoccupations of science and evidence can seem rather small and inconsequential alongside the urgent, extreme, pressing problems of public health. And there is a danger, actually, in that the science element can lose a sense of its own identity. And I think there is an attraction too, because when one works in the area of science, one of the things that one, I think, inevitably becomes rather accustomed to is people not paying you a blind bit of notice. And you end up feeling like you're working in a sort of low-grade form of the entertainment industry, rather than actually saying anything that changes very much in the world. And I think that there is then an attraction, in a way, to align oneself with movements that seem active and engaged and influential and actually doing things. And it is valuable that science and evidence engages in that way. But there is a danger, because the evidence that one assembles is not necessarily always congruent with the predominant view of those movements or those political alignments, etc., etc. And as difficult as it is to speak truth to power, it is also equally difficult to report findings which are sometimes they are not necessarily congruent with the predominant view that's being articulated by a powerful sector of society or a powerful social movement. So that's just by way of my introduction. The limits of harm reduction, well, many people in this room would say, well, there are no limits to harm reduction. There can't be. It's an absolutely valued principle. But it seems to me that apart from the love of one's family and one's children and partner, there is very little actually in life that is without limits, and probably nothing in the area of public policy. But the principle of harm reduction is often attributed or traced back to the Hippocratic Oath, the proposition of do no harm. Well, when one looks at the Hippocratic Oath, in fact, there is that principle doesn't even sit there. The closest to that principle is this: that I will use treatment to help the sick according to my ability and judgment, but never with a view to injury and wrongdoing. And that kind of conveys, in its own way, why harm is never the aim of medical interventions. And yet harm is the other side of the coin of interventions. When a surgeon cuts into flesh, or when a physician injects a newborn, they initiate actions which the non-medically trained would be paralysed with anxiety to initiate for fear of increasing the harm. And yet harm is actually an inevitable handmaiden of any kind of medical intervention. I've just listed here some of the harms associated with one drug, chlorpromazine, and those are all the side effects which one may experience some of them on taking this medication. But the extensiveness of that list shows you that even a single drug can cause multiple harms. Iatrogenic illness, the harms arising from medical interventions, are the third most common cause of patient death in the United States. NICE has estimated that healthcare-associated infections cost the NHS around $1 billion a year, impacting on around about 300,000 patients a year. So harm is not, in a sense, out there away from therapeutic or medical intervention. It's part and parcel of therapeutic interventions. It is, one then infers that harm reduction is not an absolute, even if one would wish it to be so. In fact, the reference to reduction rather than harm exclusion shows you that one's talking about a calibrated domain here rather than absolute goal. And I wanted to list some of those limitations. And I'll start with two illustrations. The first of which is needle and syringe exchange. Now, that's commonplace now in many or most countries in the world as a response to concerns about the spread of blood-borne infections amongst injecting drug users. But there was a time when the proposition to provide sterile injecting equipment was one of the most controversial suggestions being made, and it was one which was felt to be tantamount to condoning an illegal activity. But it survived those objections, largely because of the perception that the threat of HIV was greater than the threat of drugs misuse, and it has now become commonplace intervention throughout the world. There's another intervention in Glasgow in a different area called Routes Out of Prostitution, which is a harm reduction intervention, the aim of which is try to discourage women from entering prostitution and encourage women to exit from prostitution. Now, the intervention has many facets to it, including a street-level drop-in clinic with paid and volunteer staff. And some years ago, it was proposed that on the basis that most women working on the streets in prostitution in Glasgow are doing so in order to fund a drug habit, that perhaps the most effective way of encouraging them to cease working in the sex industry would be to provide an alternative source of income to them. Now, that became a very, very controversial proposition. It may have actually resulted in more women exiting prostitution than all the paid help that was placed at their doorstep. You actually pay women not to work as prostitutes. But the reason that was not sustained, that it didn't actually occur, wasn't because we felt the intervention wouldn't work. It was because of the moral, political objection to the idea of paying somebody not to work in the sex industry. And yet we are accustomed actually in other areas of healthcare interventions to pay people to elicit positive behavioural change. So although it's not commonplace, there are many ways in which patients or clients are rewarded for positive behavioural change, and in the smoking field, there's a trial currently underway where women are paid in the stages of their pregnancy to stop smoking. But in this instance, it didn't fly, and it didn't fly for largely political or moral reasons. So, what then are the limits to harm reduction? If those two case studies illustrate the moral and political climate which surrounds the whole area of harm reduction interventions. And there are, as you see here, the moral political climate There is the issue of the cost effectiveness, and we are accustomed now to considering all kinds of interventions in terms of their cost and their effectiveness. And it is no longer accepted that just because one can make an intervention, that there is a justification to intervene. And one of the limits then is to, however well-intentioned a harm reduction intervention is, to subject the intervention to an assessment of its costs and its effectiveness. There is the limit of the definition of harm and the relative importance of the harm that's being addressed. Now, my colleagues and I in Glasgow are currently carrying out work interviewing e-cigarette users and people who witness people using e-cigarettes. And we're doing that work because of the anxiety that the use of e-cigarettes is serving to renormalise smoking. Well, the interviews that we're carrying out with non-smokers, non-vapers, is actually showing that they are more critical of smoking as a result of having witnessed vaping, not less critical. So far from smoking being renormalised by the sight of people vaping, far from it, is becoming less normalised by those sights. But when we asked the non-vapers, non-smokers, whether they thought vaping should be banned in public settings, they were largely of the view that it should be banned. And the reasons for that was that they felt it was somewhat of an intrusion to have people vaping in their proximity. Not because they feared the toxic content of expressed vapour, but they just had a sense that it was intrusive to have people vaping in their proximity. Now, we know that e-cigarettes are up to 95% less harmful than combusted tobacco. So whose harm is uppermost here in terms of the commitment to reduce harm? Is it the harm that's reduced by encouraging smokers to switch to vaping, thereby not restricting their use of these devices in multiple public settings? Or is it the harm that's reported by the non-vapers? Now, you might say, well, it's obvious. One is actually reducing the exposure to a life-threatening condition. The other is wanting release from the minor inconvenience of people vaping in their proximity. So it's obvious whose harm is more uppermost here. But the fact that there are two sets of harms and they are rather conflictual there shows you that it isn't always going to be a simple case of knowing whose harm is uppermost and whose harm can be reduced, but it's of rather less consequence. Then there is the issue of balancing between harms. Now, substitute opiate medication is valuable in terms of reducing drug injectors' risk of overdose. There's a long catalogue of research showing that providing drug users with methadone has clear benefits. But that is not the whole story. So here's a study carried out in Edinburgh which tracked a cohort of patients in one general practice, most of whom were prescribed methadone, and that study concluded that yes, the drug injectors who were prescribed methadone were at lower risk of dying, which in Scotland is a substantial achievement because we have a very high level of drug-related deaths. But the prescription also lengthened substantially the period over which people remained drug-dependent. So those drug users who were prescribed methadone remained drug-dependent for many, many more years than those who had not been prescribed methadone. So here is an instance where there is a harm reduction intervention which has undoubted benefits, but it also has some significant adverse consequences. So there is the issue there of reducing harm, or in some instances increasing harm. Another area where that balance is evident is in relation to, e-cigarettes. Now, there is no question that the e-cigarettes are much less harmful than combusted tobacco, but there is growing concern that the increased use of e-cigarettes by young people, particularly in the United States, where there's been a marked increase in use of these devices, a concern that they may become another way in which people become dependent on nicotine. Now, my colleagues and I are currently analysing data from a survey of over 23,000 vapers in the United States, and one of the issues that we looked at was the level of dependency on the part of those using e-cigarettes. And somewhat surprisingly for some people, what we found is that actually a very small proportion of the 23,000 people that we surveyed using a standard measure of dependency, reported being dependent. The vast majority had low or no reported levels of dependence. Now, on the face of it, one might say that's a very reassuring finding. Low levels of dependency, especially in the context of anxieties that e-cigarettes are increasing levels of nicotine dependence in society. But in a sense, here's the rub. If you have an intervention which is much less harmful than the alternative, combusted tobacco, is it positive that so few people repeatedly use that alternative? We know that a very substantial proportion of smokers don't even try e-cigarettes, and 7 out of 10 of those who do, after having tried an e-cigarette, revert back to smoking. So you start to wonder, well, maybe the lack of dependence associated with the use of e-cigarettes is not necessarily always a positive thing. It may indicate that the intervention is not particularly sticky, that people will initially engage within it and then revert back to a much more harmful form of consuming nicotine, within which it would have been a more desirable, a more beneficial outcome would have been had they retained use of e-cigarettes for a longer period of time. So that is an issue of how one defines the harm. There is the limit, too, of how far agencies can intervene. And I think that in many instances we have a disproportionate sense of gusto where we work in agencies in our expectation that we can intervene positively in people's lives. We know, for example, that safe injecting centres, where they've been established, they attract substantial numbers of drug injectors, but they don't attract all in drug injectors, and they don't even attract necessarily all the people who are injecting all the time within those centres, who even go to those centres. Now, that's not a reason not to provide those centres, but it's an indication that people set their own limits for how far they want agencies to engage in their lives, and many individuals resist that engagement for a variety of reasons. Even the best intentioned, best planned and best delivered interventions will be used to a limited extent, limited by individuals' own reticence to engage with those services. There is a limitation too in the balance between harm and pleasure, and that within the public health field we focus principally in terms of reducing harm. But of course, harm is only one of the dimensions of people's lives, and an alternative is pleasure. So there will undoubtedly be many, many instances where people engage in activities for reasons of eliciting pleasure that are harmful, but in response to exhortations to desist from those activities or to engage with agencies which will facilitate the withdrawal from those activities, will not find a resonant receptive audience. People will resist engaging with those agencies because harm is not necessarily the principal focus in terms of the way they're organising their activities. Then there is the issue, in a sense, which Jerry raised, which is the limitations of competence. Now, it's somewhat pejorative, and it's certainly unfashionable to question the competence of staff working in agencies. But it's also, I think, rather misplaced in terms of the reassurance that it offers to suppose, without evidence, that everybody working in agencies is acting at a very high level of competence. And I think in our field, it's particularly important to establish what is the competency basis for the interventions that people are making. And they are not necessarily any longer the titled interventions, the paid worker, the professional, etc., the peer interventions by people in similar circumstances with similar experience to those whose behaviour they're seeking to change, in many ways is a site of greater competence than the professional discourse that we've been rather more familiar to in the past. And that can set limits too. So a harm reduction intervention which is staffed by people with high level of professional training may be limited, but to the extent that those very same people do not share the common experience with the individuals whose lives they're trying to beneficially change. And then finally, there's the issue of the timeliness of the harm that's being reduced. We typically evaluate interventions in terms of their impact on the lives of individuals in the here and now, current clients, current patients. But of course, any interventions that is really going to have substantial positive value has to have an impact over time, and preferably have a beneficial impact not only on current generations but on subsequent generations. And it may well be that some interventions which in the short term increase harm will be accepted and promoted if they deliver longer term harm reduction to subsequent generations. Now, I'm not going to offer particular illustrations of that, but it raises the issue of what's the time frame that one should use. Finally, I would just sum up by saying that harm reduction is not a call to arms, although it is very much a powerful and influential social and political movement. And it is important that it is that. But the contribution of evidence should not be to be swept up in the enthusiasm of a social movement. It is to retain a commitment to establishing the effectiveness of those interventions, their cost, whether they're congruent or not, convergent or not with current political moral orthodoxies, whether they're effective, whether they're desirable, whether they are being delivered in the best way. To subject those interventions to critical assessment at the same level as would be appropriately targeted at other interventions, which are of a rather different kind. And my own feeling is that harm reduction interventions will not be best served by compromising those principles of academic assessment. They will be enhanced by adhering to those principles of academic assessment, but the sweet elixir, if you like, of finding great favour with individuals or organisations that one may align oneself with in the research which one carries out, is something to be very, very cautious about. In just the way that I indicated at the start that speaking truth to power is difficult to do and costly, so too it can be difficult and costly to ensure that the best available research is carried out on interventions which are motivated by the best of intentions. Thank you very much.